Hello, my name is Patrick and I'm a Pulmonary and Critical Care Fellow. This video is on anaerobic threshold and VO2. It is part of a wider CPET series. These two chest x-rays show us two different central venous catheters. Here we have a triple lumen catheter which is in the SVC just above the right atrium, and over here we have a pulmonary artery catheter or a Swan-Ganz catheter. Both of these are in the venous system, however they're measuring oxygen levels that are quite different. At rest, a triple lumen catheter is draining predominantly the upper extremities and the brain and will actually have a lower venous oxygen content, where a pulmonary artery catheter will have a lower oxygen content during exercise, because not only is it draining blood from the upper extremities and the brain, but it's also draining from the coronary sinus and the lower extremities. And we call this a mixed venous O2, and it is this mixed venous O2 that we use later on as part of the Fick equation to calculate a VO2. Here we have the Fick equation, which is your cardiac output is the sum of your VO2 divided by your arteriovenous difference, and your arteriovenous difference is your arterial oxygen content minus your venous oxygen content. And when we rearrange that, we can come up with the equation for our VO2, which is cardiac output multiplied by the arteriovenous difference. To recap, your VO2 is your oxygen uptake. It's the volume of oxygen that you've extracted from the inspired air in a given period of time. Your anaerobic threshold, or your AT, is the exercise VO2 that marks the transition between no change in arterial lactate and the sustained increase in concentration of lactate. Your exercise VO2 above which anaerobic energy production substantially supplements aerobic energy production. So your anaerobic threshold is a point on your VO2 scale. And secondly, I want to highlight that anaerobic metabolism supplements aerobic metabolism. It's not binary, it's not aerobic then anaerobic, it's aerobic then anaerobic and aerobic. I'd also like to highlight that VO2 max is not the same as VO2 peak. While they're very similar, they're not the same. VO2 max is typically tested for in elite athletes in special labs, and it is the point during exercise where there's a plateau of VO2 despite the work rate increasing. VO2 peak, on the other hand, is what we typically test for clinically in patients during a clinical CPET, and it is simply the highest VO2 that they reach during the test. VO2 can be expressed as mils per minute, or liters per minute, or mils per minute per kilo, adjusting for weight. You may also hear people refer to anaerobic threshold as ventilatory threshold or lactate threshold. Some authors prefer the term ventilatory thresholds because the transitions in metabolism are being detected using exercise-induced changes in ventilation rather than invasive blood work. This is what I refer to as the vicious circle of your 30s, where you might feel compelled to couple up, have babies, buy property, and become a runner. If this looks like you or someone you know, then you may have come across heart rate zones and heart rate zone 2, and you may have had conversations with other runners about how to maximize your aerobic fitness. So hopefully in the next few slides I can explain what training actually means and the adaptations that occur in our body. So here we have the 5 heart rate zones. This image is actually taken from the Cleveland Clinic's public website, and each zone has a different purpose. Our anaerobic threshold typically lies in zone 3, and if we were to take a patient who's 30 years old and work out their predicted max heart rate, the most common and clinically used calculator is 220 minus their age in years, which would give this patient a max heart rate of 190 beats per minute, and for them to stay in zone 3, their average heart rate should be about 145 beats per minute. So now, remembering the Fick equation that we've repurposed for VO2, we'll use 2 different examples of this 30-year-old runner. On the first day, we have the patient go out and run 6 miles at a very respectable 9 minutes a mile. Their heart rate is 145 beats per minute on average. Their stroke volume is about 100 mils per beat. Their arterial oxygen content is 20 mils per deciliter, and their venous oxygen content is about 10 mils per deciliter. This gives them an arteriovenous difference of 10 mils per deciliter. And when you multiply this all out using that equation, you get a VO2 of about 1.5 liters per minute. Now, on the second day, they're feeling very good and they decide to go for a hard, fast run. So they run 1 mile at a 6-minute mile. They maximize their heart rate at 190 beats per minute. Their stroke volume is the same as the day before. It was 100 mils per beat. Their arterial oxygen content is the same, it's 20 mils per deciliter, but their venous oxygen content is less, it's 3 mils per deciliter, giving them an arteriovenous difference of 17 mils per deciliter and a VO2 of about 3.2 liters per minute. And while these numbers are imaginary, this is relatively accurate. Our anaerobic threshold is typically about 50% of our VO2 max. And here you can highlights the impact that the arteriovenous difference makes in our overall VO2. Now, with consistent training, this slide hopefully shows some of the changes that our bodies make to adapt to aerobic exercise. So if we take day 1 that we just talked about and we compare it with a year later, this person goes out and they run another 6 miles, the same 6 miles, but instead of running it at 9 minutes a mile, they run at a pace of 7 minutes a mile, very, very fast. Their heart rate average is the same at 145 beats, but what's different is their stroke volume has increased to 150 mils per beat, where previously it was 100 mils per beat. And this happens with exercise. We can have structural adaptation, we can have left ventricular hypertrophy, and this is why athletes, typically young men, if they were to have an electrocardiogram or a transthoracic echo, they can be diagnosed with left ventricular hypertrophy. The next thing I want to talk about is the arterial oxygen content. Here you can see it's increased to 22, whereas previously it was 20 mils per deciliter. Now, this is the same atmospheric oxygen that the patient is breathing. However, over time their body has adapted and they have a greater hemoglobin concentration, so they're able to carry more oxygen. You'll also notice that the venous oxygen content is lower than it was a year ago. And the reason for this is that over time they've increased their amount of muscle, they've increased the capillaries feeding that muscle, they've increased the number of mitochondria, the density of mitochondria, and the efficiency of mitochondria. So they're able to extract more oxygen from the blood that's being delivered. And this gives them a greater arteriovenous difference. So when you multiply all this out, you can see that their VO2 has increased from 1.5 liters per minute a year ago to around 3 liters per minute today. And this is true. With training, we can increase both our VO2 max as well as our anaerobic threshold. So knowing what we know about the adaptations that happen within our body, how can you get an edge? How can you get a competitive advantage on people with this information? Well, you can increase your arterial oxygen content, and you can do this a few different ways. You can do what's called blood doping. You can exsanguinate yourself, allow time for your body to compensate, and then transfuse that blood back into you to give you a higher hemoglobin so that you can carry a higher oxygen content. Another thing you can do is you can use erythropoietin or EPO to stimulate your body to make more hemoglobin. And thirdly, you can train at altitude, where the relative hypoxia naturally stimulates your body to make a higher hemoglobin. And one famous professional cyclist who you may know who did these things is this cheeky cyclist in the top right, Lance Armstrong. This is Carlman Wasserman's famous gear wheel analogy for how we think of a CPET and the physiology that we're testing. On the right hand side, you can see we have ventilation. In the middle we have oxygen and carbon dioxide transport, and on the left hand side we have the muscle activity in the mitochondria. And if we follow the path of oxygen being inspired in the lungs, making its way through the pulmonary circulation, through the heart and the blood to the peripheral circulation, where it then makes its way into the muscle and eventually into the mitochondria, where it helps, in addition to a substrate, produce ATP. Carbon dioxide is then produced and works its way backwards through the circulation to be exhaled as carbon dioxide. Another way you can think about this process, if you prefer equations, is you can firstly think of the alveolar gas equation, and this is measuring the gas in the alveoli and in the arterial system, and looking for any type of arterial alveolar gradient increase. And that's the first step of the process. The next step of the process is looking at the arterial oxygen content, which is your hemoglobin multiplied by 1.34, multiplied by oxygen saturation, as well as that little bit of oxygen that's also there. And if you have an increased AA gradient, then you will have a reduced oxygen saturation. The next part of the equation is the DO2 equation, or the delivery of oxygen equation. This is your cardiac output, which is your heart rate times your stroke volume, multiplied by this arterial oxygen content. And lastly, to drive home my point, the VO2 equation is very similar to the DO2 equation, except that instead of just talking about arterial oxygen content, we also have the venous oxygen content and the arteriovenous difference, because this represents how much oxygen the body is actually extracting from the blood that is being delivered to it. So now let's take a second to just focus on zone 2 of the 5 heart rate zones and why it is so popular. If you can see here, zone 2 is that 60 to 70% of your maximum heart rate, and here from the Cleveland Clinic they recommend targeting it when you're trying to build endurance or burn fat. So in the next slide we'll talk about why that is. Now this is the respiratory quotient. This is the volume of carbon dioxide produced divided by the volume of oxygen consumed. And if the goal of metabolism is to release hydrogen ions to produce ATP, then it makes sense for us at rest to burn fat. One, because it's plentiful and we're very good at storing it, but two, it has a much higher yield of hydrogen ions. If we contrast that to glucose, which has maybe 12 hydrogen ions, fat you can see has 32 hydrogen ions. During exercise we burn glucose, which is already half oxidized, but we have relatively little of it. The reason for that is it's kept for during exertion when oxidizing fat would take too long and need too much oxygen. Here you can see that this glucose is already half oxidized, so only needs 6 molecules of oxygen to complete the process, whereas this fat is very poorly oxidized and needs 23 molecules of oxygen to complete the process. And when we divide the volume of carbon dioxide produced by the volume of oxygen consumed, we get a respiratory quotient of 1. And when we do the same for fat, we get a respiratory quotient of 0.7. Now, this is the respiratory quotient, and this is what we imagine is happening at the cellular level. So during a non-invasive CPET, where we're not drawing any labs, we infer that this is happening by measuring gas exchanges with a face mask, and we call this value the respiratory exchange ratio. This last slide is just to highlight again that during exercise, our anaerobic metabolism supplements our aerobic metabolism. Here you can see during aerobic metabolism we have oxygen that makes its way to the muscle and the mitochondria, where in addition to the substrate, energy and carbon dioxide are produced and then leaves the body. But during the addition of anaerobic metabolism, we have that carbon dioxide produced from aerobic metabolism in addition to additional carbon dioxide being produced as well as lactate. And that's why with sustained exercise and sustained anaerobic metabolism, we have this huge increase in carbon dioxide being produced, which then eventually consumes all of our blood's bicarbonate.